Hello everyone. Today we will be going to discuss on Bell's palsy. Myself, Dr. Vinayakrishna, Additional Professor, Department of Maxillofacial Surgery, Yenepoya Dental College. These are all the objectives we are going to look upon today. By the end of this lecture, students should be able to define Bell's palsy, differentiate between UMNL and LMNL, that is upper motor neuron lesion and lower motor neuron lesion, explain the clinical features and Bell's phenomenon or Bell's sign, what you call, and understand the various treatment modalities for Bell's palsy. Let's move on to one by one. First of all, we will start with the basic anatomy of facial nerve. In brief, facial nerve is the 7th cranial nerve, as we all know, and it is a nerve of second brain clock. It is a mixed nerve which has got both sensory as well as motor, a major motor nerve. Sensory nerve or sensory root is nervus intermedius. The nuclei of facial nerves are main motor nucleus, chief sensory nucleus, that is tractus solitarius for the taste, lacrimatory nucleus and superior salivatory nucleus for the salivary secretions. So, muscles which are supplied by the brachial motor, that is special visceral efferent, supplies the muscles of the facial expression, posterior belly of digastric, stylohyoid and stapedius muscle. Visceral motor, that is general visceral efferents, are parasympathetic of the lacrimal gland, submandibular and sublingual gland through submandibular ganglion, mucous membrane of the nasopharynx, hard and soft palate. Through the chorda tympani nerve, which goes along with the lingual nerve, from the anterior two-thirds of the tongue, the taste is received. It is special sensory, that is also a branch of facial nerve. General sensory, that is general somatic efferent, a small part, that is general sensation from the skin of the concha of the auricle and small area behind the ear. Motor nucleus, as you can see in the picture, part of nucleus that supplies upper part of the face receives corticonuclear fibers from both cerebral hemispheres. Part of nucleus that supplies lower part receives fibers from opposite cerebral hemispheres. Let us move on to the neuron lesions, that is upper motor neuron lesion and lower motor neuron lesion. Then we will move on to the Bell's palsy. Now, upper motor neuron lesion is nothing but, as the name indicates, the lesion or the damage which occurs at the level of the brain, that is upper motor neuron lesion. Hence, you can see neural cell bodies in the cortex of the axons that project via the corticobulbar tract. Voluntary control of only the lower facial muscles expressions on the side contralateral to the lesion will be lost. Suppose the lesion is on the right side of the brain, the facial expression on the lower portion of the left side of the face is lost, whereas the upper part of the face is spared because of the crossover of both the sides will get the connections, nerve innervations. So, voluntary control of muscles of the forehead will be spared due to the bilateral innervation of the portion of the motor nucleus of the cranial nerve 7 that innervates upper muscles of the facial expression. So, facial asymmetry will be seen, atrophy of the lower portion of the face. Remember, it is the upper motor neuron lesion, the lower face is affected. No eyebrow droop will be seen, smoothing of the nasolabial folds on the affected side will be seen. Lips cannot be held tightly together or the pursed, difficulty keeping the food in the mouth while chewing on the affected side. Now, let us see what is lower motor neuron lesion, that is LMNL. So, whenever the injury or the lesion is beyond the stylomastoid foramen, at the level of stylomastoid foramen or beyond, so that all the branches, terminal branches of the facial nerve is affected, is termed as lower motor neuron lesion. The name itself says lower motor neuron means beyond the stylomastoid foramen. So, once the nerve exits the skull, you can see the picture clearly demonstrates entire one side of the half of the face is affected. Now here the lesion, if it is on the left side of the face is affected, whereas in the UMNL it is the opposite or the contralateral side. So results in paralysis of all muscles of facial expression, including those of the forehead on the ipsilateral side of the lesion. So that is a basic difference between UMNL and LMNL. You can see the clinical correlation here. LMNL lesion of the cranial nerve 7, which occurs at the beyond or stellamastoid foramen, is commonly referred to as Bell's palsy. So that is how we define Bell's palsy. Moving on to also, you should remember it is the LMNL, that is lower motor neuron lesion, is nothing but we call it as Bell's palsy. So let's look into the Bell's palsy definition. It is defined as idiopathic paresis or paralysis of the facial nerve of sudden onset. It's unilateral lower motor neuron lesion, paralysis of sudden onset, not related to any other disease elsewhere in the body. So it is idiopathic, we don't know the cause, it is etiology is unknown. Then it is termed as Bell's palsy, ascribed to Sir Charles Bell, who in 1821 demonstrated the separation of the motor and sensory innervations. So incidence of this Bell's palsy is 15 to 40 cases per 1 lakh. Women are affected more, 3.3 times more common in pregnant women, prevalence in 3rd trimester or first week of postpartum, more in diabetic patients. It can occur at any age, more common in middle age, both sides equally affected. 1% it is bilateral, very minimal, you can see bilaterally the facial nerve is affected. 8% cases positive family history we can see. So there are different hypotheses put forward why this happens. The rheumatic hypothesis by Berard in 1936, rheumatic swelling may press the nerve against the facial nerve canal. That is the reason why the Bell's palsy or the facial paralysis is seen. Whereas cold hypothesis by Bell, exposure to extreme cold or cold rot leads to Bell's palsy. Ischemic hypothesis, ischemia from disturbed circulation of the blood. Immunological hypothesis, in vivo sensitization of lymphocytes to peripheral nerve myelin sheath. Viral hypothesis, that is herpes simplex virus, elevated viral antibody titer and interference. Facial palsy plus herpes simplex is termed as a syndrome that's called as Ramsay-Hunt syndrome. So these are all the different hypotheses which are put forward. Factors producing the vasospasm like cold, anoxia, carbon dioxide excess, vasomotor instability, injury, toxic, allergic, hormonal influence, these are all the different factors which suspected to cause Bell's palsy. Now let's see what are the different clinical features of Bell's palsy. The sudden onset, usually in the morning after awakening, is the commonest symptom of Bell's palsy. It's unilateral involvement of the entire face, on side of the face. Corner of the mouth droops down, causing drooling of saliva. Whistling or puckering is impossible, difficult. Excessive tearing is seen because of inability to close the eyelids. Inability to close the affected eye or wink, raise the eyebrow. And what is Bell's sign? In an attempt to close the eyelid, the eyeball rolls upward so that pupil is covered and white sclera is seen. This phenomenon is called as Bell's phenomenon and also mentioned as Bell's sign. Inability to wring the forehead, inability to elevate the upper or lower lip. It's all the typical features of Bell's palsy. Widening of the palpebral fissure, loss of blink reflex, obliteration of the nasolabial fold, mask-like face, slurred speech, loss or alteration of taste occasionally is seen. Prognosis of the Bell's palsy is not that difficult to understand because it's spontaneous, so that its spontaneous recovery is in most of the cases. So initial weakness of the facial musculature is seen, which worsens over 2 to 3 days of time and becomes maximum by 2 weeks of time and gradually start remission, and spontaneous recovery is seen after 3 weeks or 4 weeks of time. House-Brackman classification of facial palsy we can look into. Different grades are put forward, 1 to 6. Grade 1 is normal function without much weakness. Grade 2, slight facial asymmetry with minus synkinesis. Grade 3, obvious asymmetry with residual forehead movement. Grade 4, obvious disfiguring asymmetry with lack of forehead motion and incomplete eye closure. Grade 5, asymmetry at rest and only slight facial movement is seen. Grade 6, complete or absence of tone or the motion. So this is a very important classification by House-Brackman for facial palsy. Now let's see what are the different treatment options for Bell's palsy. The first and foremost, since it is idiopathic and most of the time it is spontaneous remission is seen, we can see reassuring the patient since it is most of the time self-limiting. And sometimes we may have to assist that with the steroids, antiviral drugs, physiotherapy, massaging of the affected side, closure of the eye or eye cover is must so that we will not have dryness of the eye. In case if it is not spontaneously regressing or remissing, then we may have to go for surgical intervention. Facial nerve decompression is the first and foremost which is put forward. Facial reanimation is another method where you can imitate or improve the facial appearances on that side. Nerve decompression can be carried out internally or externally. Internal decompression, the nerve is exposed in the fallopian canal and pressure in the canal is relieved by exposing the nerve and the epidural sheath is opened to visualize the nerve fibers and release adhesions or re-establish the continuity. External decompression is done by releasing the epidural sheath from the surrounding tissues, bone or foreign body. Facial reconstruction or reanimation is another method of treatment where nerve interposition grafting is done, bridges the gap between the nerve defect if there is a physical defect. Hypoglossal facial nerve end-to-end anastomosis of cranial nerve 12 and cranial nerve 7 is done. Contralateral facial nerve graft is also another consideration where it uses the donor nerve to bridge a damaged facial nerve to the contralateral or unaffected facial nerve. Muscle bundle can be transferred. For example, temporalis muscle can be tunneled and transferred to the normal side from the affected side. In the affected side, muscles are no longer visible, you can use that. Microneurovascular free flap transfers also tried. Transplants from the remote donor sites, you can transplant microneurovascular anastomosis and the normal function of the face can be re-established. You can see the nerve grafting. Whenever there is evidence of neuroma or loss of portion of the nerve grafting can be considered. You can see in the picture, the nerve grafting can be chosen and you can choose which area to be grafted and you can re-anastomose that with the nerve. You can see re-anastomosis, nerve anastomosis with reanimation. Anastomosis of the central end of the hypoglossal or spinal accessory nerve with the distal end of the facial nerve is done so that we can re-establish the function of the facial motor function of the facial muscles. If there is a long-standing Bell's palsy which is not recovered, the patient's eyelid may go for a paralysis and it will not be able to close. So we may have to consider putting a weight in the eyelid so that the eyelid can be closed partially so you can protect the eye, drying up the eye. Surgical correction like gold weight can be implanted onto the upper eyelid and you can close it, which is biocompatible and not going to cause much problem. Because of the weight, the gravity, the eyelid is going to close. So these are all the options we have to treat the Bell's palsy, which is most of the time spontaneously regressing. If not, we have to consider other options. So in summary, I would like to say that Bell's palsy is an important topic in maxillofacial surgery. Quite a number of times we will come across with this situation, and its diagnosis depends on the history, clinical features mainly, and also requires a very pragmatic approach for the proper management of the Bell's palsy so that we will have least complications or the patient's confidence can be gained. Thank you.